DBT is not a suicide prevention program. It is a life enhancement program. And that is, in my mind, as a therapist, I think about that a lot with phone coaching. I will give you my time, but I can't get to somebody because I'm giving this other person that I'm in session with my time. And so if you are in crisis and you can't keep yourself safe, use your skills, try phone coaching. And if you still can't keep yourself safe, you got to go to the emergency room.
This is Hope to Recharge. I'm Atana. I'm here to guide you and support you through your challenging times, navigating through depression, anxiety, and other mental health struggles.
Welcome to today's episode of Hope to Recharge, where Matana sits with Meg Rowley to discuss borderline personality disorder. What are the symptoms? Is the stigma warranted? How about treatment? Is recovery possible? All this and more in our 4-part series. Meg Rowley is a licensed clinical social worker who has been an integral member of the DBT adherent treatment team at BHBA for the past 5 years and has a private practice in Vermont. She received her graduate degree from Columbia University of Social Work, where she was intensively trained in dialectical behavior therapy training program and lab, and is currently working toward DBT Linehan board certification. Meg's passion lies with treating and assisting people in healing from PTSD and traumatic memories. She is trained and has received certification in eye movement desensitization reprocessing, EMDR therapy, and is trained in dialectical behavior therapy prolonged exposure, DBT-PE protocol, exposure and response prevention, EXRP therapy, and radically open DBT, RODBT, and has extensively studied the treatment of disordered eating and body image dissatisfaction. We welcome you to today's episode.
Thank you for joining me here today. Today I call her my hero, but I don't even really know her. I know her through my friend because Meg Rowley is my friend's therapist for many years. And for many years, I've been saying she is the epitome of what therapists should be like. A lot of empathy, a lot of boundaries, a lot of clarity, and the ultimate vision is how far can we get my client to achieve a better being? And the ego never comes in the way. What I see from my conversations with my friend, I'm like, my God, this therapist is literally the ultimate therapist. My friend introduced me to the world of borderline. And I literally didn't know the word borderline before she told me she was diagnosed with borderline. I had to Google it. And I didn't understand why she was so upset about it. I'm like, okay, you got a diagnosis. Why are you upset? Hello, Meg. Thank you for joining me
I'm
here.
excited to be here and talk about this issue. It's so important and dear to my heart. So thanks for having me.
Thank you for allowing me to pick your brain and your experiences and your vision. And the reason why I reached out, I asked my friend, can you ask your therapist if she's willing to be on my podcast? I said, it's going to be a few series podcasts. The more I learn about borderline, the more I realize there's such shame, such misunderstanding, such stigma, and we need to change that. And it's going to change with
Yeah.
time, right? And I said that I wanted to have you on because I personally, with my own eyes, saw her transformation from the pits of hell, which I didn't even think that she would survive. I remember her calling me. I remember where I was in the car when she called me. And she said, I don't know if I can take another day of this misery. What should I do? And she was looking into different options because she could not go with the pain and the frustration and the trauma. She had such courage to do the research, find the right PHP program. And then she was diagnosed while she was on this healing journey. She was diagnosed with borderline. And for her, it was, I think, the biggest relief. Oh my God, there's a name, there's a way to heal from this. There's a path. Others healed from it. I know why I'm feeling like this. There's hope. I remember when she called me and it took her time to tell me her diagnosis. And I'm saying months that she said I was diagnosed. I'm not going to tell you yet. And I didn't understand. And then after she
Yeah.
brought me into this whole world of borderline and I started researching and I realized that the most downloaded episodes on our podcast is on borderline for the last 2 years. That means so many people are hungry for knowledge, hungry to understand, hungry for help, hope. So, Meg, our mission in this next few episodes today is going to be like just introducing borderline, understanding borderline. Just like me, I didn't know anything about it and I want to know more about it. And it's important because it's a word that's being thrown around a lot. And we need to understand the heaviness that the world is feeling with the word borderline. And I think just explaining from the perspective of a therapist will give clarity about what is it? How does one get diagnosed? Can one heal? What do you see in your practice? Giving hope, breaking these stigmas, breaking misunderstandings, and really giving insight to the world of DBT, this big DBT world of healing. So I think we're going to start off with just understanding the difference. You're a general therapist, but you specialize in DBT. So let's just give the audience a synopsis of why did you become a therapist and what made you go into helping people with borderline heal with DBT.
I'm a licensed clinical social worker and general therapist, psychotherapist. I started my career towards being a therapist, working in a domestic violence agency as an advocate. And at that time, I had an undergraduate degree. I had no concept of wanting to be a therapist, but I just knew that I really wanted to serve the community that I was living in. And at the time, I was like, okay, I certainly can change, bed sheets and things like that and check people in. But during my time at the shelter, it became clear that I wanted to do more clinical work. I wanted to do therapy with people, and I wasn't really able to do that with the education that I had. So I decided to get my master's in social work because I just felt really drawn to it. And I'm helping people this way, but I really want to help people behaviorally change on a deeper level. I applied to graduate school, and while I was there, I went to Columbia University School of Social Work in New York. And within that program, they had this amazing program all about DBT that made you do deep, intensive dive in DBT. And it was about 12 months. I was very much drawn to that because it was tangible skills. When you go to social work school, they throw a lot at you, but I really wanted a tangible group of skills that I could use when I got out there in my clinical practice. And so that's a very short version of like how I was drawn to being a therapist and how I became interested in and heard for the first time of DBT. That's not true. There was actually at the shelter, there was a book. It was a skills handbook, the DBT skills handbook. And I thought, this would be so amazing for our clients. And I said to the clinical head at the shelter, can we teach people these skills? And nobody had training in DBT at that time. And so I said, yeah, nobody had training in it. We had the book, we had the handbook. And I went through them and I said, this would be so life-changing for people. And she was like, yeah, but we don't really have the training right now. So that was something that I always had in the back of my mind when I went to grad school of like, I got to learn more about that DBT thing. That's all. That sounds like it could be really helpful.
Wow.
Yeah.
So when you were in social work school and grad school, did they touch upon borderline in a deep way, or they just like skimmed through it? What was your experience when you were learning about borderline?
The general sort of social work school, I learned very little about borderline, like very little about borderline. But because I had applied for this other program that had actually been in collaboration with Marsha Linehan and Dr. Hoff is the head of that program at Columbia, it was a deep dive into borderline. It was all about DBT. It was all about borderline, but in a way that really talks about the dialectical nature of the diagnoses itself, how it's important, but it can also be pretty easily stigmatized and harmful, and how really DBT and the creation of DBT was a non-stigmatizing, non-pathologizing way of looking at this set of behaviors and treating the behavior rather than saying what happened there. It was just like, what are we seeing and how can we treat this and get somebody relief in this moment? And I thought that was really powerful. And within kind of talking about borderline, we learned a lot about the biosocial theory, which kind of underpins DBT. and why DBT is created the way that it is, which is pretty cool.
So basically, what I'm understanding is that the average social worker doesn't know a lot about borderline in depth and how to treat it. Is that a correct statement?
I would say that is a very accurate statement, is that I had colleagues who were in the same social work program, but not in the DBT program, that still, what is that thing where, a lot of the judgments, like, why would you want to do that? Or that sounds so hard or difficult to do that. And so there was a lot of misinformation, even among other social workers.
The clinicians themselves.
Exactly. Yeah.
What is the stigma that you, as a social work, let's go back to you as a student. What are some stigmas that the buzzwords that you were hearing when it comes to borderline from teachers, from professors, from literature, from other fellow students? What are those stigmas?
Really difficult clients. Really difficult clients. I'm even hesitant to use the language here, but manipulative, they never heal, they never get better. You're going to put so much time and resources into those clients and see very little relief from that population. I've heard clinicians say, I do not work with clients with borderline. I refer them out. So a lot of just even saying that, I feel heavy saying,
Yeah.
because it's,
Yeah.
what hope can you have when it's just, I don't work with those people. And so there's a lot of fear.
And in a way, I don't think it's wrong to say I don't work with those people, but it just shows lack of education for grouping it to, oh, I don't work with that because I can't. I feel like I can't because I don't have the tools and the skills and they didn't give it to us. So that's a problem.
Yeah,
And that shows that the stigma is coming from on top. What I'm just realizing through our conversation now that the stigma is not from the clients and their family members and the buzz. It's coming from the top.
absolutely. Yeah. Yeah. It's coming from the very top and filtering down for sure.
Wow. Wow. So with all this stigma, you weren't afraid? What gave you the courage to say, you know what? Everybody's telling me I won't see results with clients. This is like a tough community. It could be draining. What made you say, I'm going in anyway? I'm doing this. I'm all in because now you're basically full-time DBT clinician, right?
Yeah. Full-time DBT clinician. I think what drew me to the work was, my own personal struggles as a younger person through my teens and 20s, and engaging in a lot of behavior that I think a lot of clinicians probably wouldn't have wanted to work with it. Seeing that,
Mm.
going through my own hell. And what do we do? What do we do with folks who have these behaviors? Somebody has to treat them. And having my own experiences that were pretty scary at the time, I know that change is possible. I know that behavioral change is possible. I've lived it. And I also think that another thing that really motivated me to continue to do the work and say, I really want to sign up for this, is DBT and the training that I got in DBT in grad school, because the treatment itself is, I think a lot of times people say it's very structured, and there's a reason for that, because you are treating high risk behaviors, but having a treatment that is as beautiful and nuanced and structured as DBT gives you some confidence to go into these situations and say, I have a set of skills that can help here. And so I think that it was like a combination of my own personal experiences and like what I wanted to do as a therapist, and then having sort of the support and structure of DBT. Yeah.
Who was your mentor slash hero slash guiding light when you were going through your experiences?
Oh, that is a really good question.
Did you have a therapist?
I had many therapists. I don't know if there was one person. There are a lot of people, and there are a lot of different therapists that helped along my journey. And then I think people in my life, my family, friends that didn't leave when things were really scary. That's pretty powerful.
So what I am understanding that you have a lot of sympathy and empathy because you know how something can be misunderstood and frustrating and to be in this in the as you said the pits of hell, you use the same terminology and you don't want to be alone in it, and you want to be that guiding person, or saying, Take another step. It can get better. Really. Look at me. It could get better." Now, I don't know your story, and I don't know your diagnosis. It's not for that. It's not for now, but it doesn't really matter. I often said it doesn't matter what hell you went through, but if you went through a form of hell, you know that it's dark, it's scary, it's lonely, and sometimes you feel hopeless. And if you have somebody that says, "Okay, we can do this. We can go through it." So I always say there has to be a bigger why, and I'm understanding for you that your why was not only the skill book that made sense, it was, "I want to gift this to somebody because I had the blessings and the privilege of being gifted from many different people in my life, and I want to be that for others."
Absolutely. And I think I truly know that feeling of engaging in behaviors over and over again that are hurtful to yourself and harmful to your relationships. And to look back and say, why am I doing this? Why? But not be able to stop or to change it. And to know that is possible to change those behaviors and to get a different outcome. Man, that's my life mission to be
Yeah.
able to share that with other people who are struggling in that same way.
That's beautiful. That's beautiful. So let's deep dive into borderline. What are we doing to help ourselves improve and heal? What's important to us? How can we cultivate small changes in our brain, in our day to day life with our own tools? Sometimes this process is very lonely and hard. Sometimes you need a therapist, a psychiatrist, and somebody like me, somebody that went through the same thing. And I love working with people that are ready to do the work because it is expensive. It's a lifelong investment into yourself, into your future. When you start working with me, you're investing into your long-term stability, into your long-term mental health. What are you willing to do to make the changes? You could say, "I don't know what I want. I don't even believe things can change, but I'm no longer willing to stay in this position where I am now." Choose yourself. If you want to work one-on-one, link is in the show notes. Schedule a free 30-minute consultation and be ready to see a different you. By the way, one of the things that I never understood before we go into how do we define borderline, what are the traits, and how do we diagnose? What's this word, borderline?
Yeah.
The borderline personality disorder. Like, I keep on thinking about the name that is odd.
It is odd, and it's incredibly controversial still, and really even around the development of it. And just a little bit of history around sort of the term of borderline is it first popped on the scene in 1938. The psychoanalyst Aldous Stern used it to describe patients that he was working with that he described or thought that their behaviors bordered on psychosis and neurosis, right? And they would display these behaviors where sometimes they'd be totally functional, and then other times they would have, these big behavioral outbursts. And it was highly controversial. There was a lot of back and forth for about 50 years. Do we use this term? There was a lot of folks, even at that time, over that 50-year period before it was officially entered into the DSM-5 or the DSM-3. The DSM is the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders. And we're currently on the DSM-5, but there's been 1, 2, 3, 4, 5. So it's really evolved over time. And this is like your handbook, right? It has all the diagnoses in there, but it has evolved greatly over time. And it can be controversial, like what diagnosis gets put in to the DSM-5 and who decides exactly, and what do we call it? Like, do we call it borderline personality disorder, or do we call it emotionally sensitive? And over that 50-year period, there was a lot of discussion around it, but ultimately they decided to have it enter the DSM-3 in 1980. So that was when it officially became a diagnosis that was entered into the DSM.
With a treatment then, or no treatment then?
There was not much treatment at that time. Psychoanalysis was a very big way of approaching therapy. And so there wasn't really this is how you treat this. It was, this is what we're seeing, this is what clinicians are seeing, and this is the name that we're going to give it because we see these behaviors bordering on psychosis and neurosis. But it's still it was a controversial name to give it then, and it certainly is still a controversial name to have for this.
How do we diagnose borderline?
There are 9 traits, and to meet criteria, you have to have at least 5 out of those 9 traits, those 9 sort of criteria. The disorder itself is characterized by a pattern of instability in interpersonal relationships, self-image, mood, and marked additionally by impulsivity, really beginning in early adulthood. And I can go through quickly those 9 sort of criteria. They say there's frantic efforts to avoid real or imagined abandonment, a pattern of instability and unstable interpersonal relationships, which really alternate between extreme idolization and then devaluation. So this black and white thinking there in interpersonal relationships. The third criteria is marked and persistent unstable self-image or sense of self, like who am I? I don't know who I am. I feel like I don't really know myself.
What does that mean? Who does know themselves? I'm thinking, I'm 47 years old. I have no idea who I am. I keep on asking myself every day, who am I? What am I here for? What am I doing?
That's a really great question. And I think it's just feeling maybe even one day I wake up and I'm feeling very much aligned with this way of thinking. And the next moment I'm swinging over to this sort of area. I don't know, what my interests are. I don't know what I like. I don't trust myself either. There's a sort of lack of belief and ability to make decisions that are in your best and in your wise mind, if you will, using some DBT language there.
I feel like a lot of people struggle with that.
I feel like most people do.
That's evolution of humanity. And right, that's midlife crisis, that's teenage, that's adulthood, that's parenthood. There's so many stages of life that we go through that, but we go through it just saying, okay, maybe it's the amount of empathy we give to ourselves when we go through it without the judgment part. Maybe. I'm just thinking that sounds like something that so many people.
And I think that's such a great comment, is that like that not everyone feels that, but it's a pretty human experience to have a sense, an unstable sense of self. And so when looking at it, you're like, yeah, I think a lot of people would meet that criteria.
Right.
For sure. And that's one of them. Let's see. The next one is impulsivity in at least 2 different areas. And that includes what kind of, I think, is pretty popularly attributed with BPD is self-harm. So self-harm, spending, substance use, sex, binge eating disorders are common. And so impulsivity in at least 2 of those areas.
One second, I want to just define for my mind. How does the therapist diagnose impulsivity in itself for anything?
At least through a DBT lens. Impulsivity, the way you would get at that would be you use a chain analysis. So you're talking about like what was the prompting event? Okay, I thought about that. And then what happened? I didn't think. I just did it. I just acted. And so you're also trying to look for patterns. Was it a one-off? Or is this something that is consistently happening that sometimes the individual is engaging in impulsive behavior where they look back on it and say, oh my gosh, why did I do that? Or I can't believe I did that. Or you're looking for impulsivity in at least 2 of those areas. And then you're looking for the 6th criteria is reoccurrent suicidal behavior. And that can include anything from a gesture or a threat to self-harm. Saying, I'm going to kill myself, that definitely falls into that criteria. Planning, having a plan means those type of things. The 7th area is chronic feelings of emptiness, which again, who hasn't felt that? What human hasn't felt that? The 8th criteria is intense anger or difficulty like controlling anger. And then the 9th one is dissociative symptoms. And if you're meeting 5 out of those 9 criteria, you're meeting criteria to be diagnosed with BPD.
So I'm hearing 9 traits, and you're saying you could be diagnosed if you have 5. I'm sure there's a way of saying how frequent, right? Like I'm thinking, okay, I never attempted suicide. When I was severely depressed, I was always thinking, I want to live, but I might kill myself because I don't want to live through this pain, but I don't want to kill myself, but I don't want to live through this pain. So I don't know if that's under the category of suicide, but I feel like I experienced almost all, and I don't self harm, but I feel like all of these things are human traits. That's permit like literally being human. So how does a therapist diagnose borderline when all these traits can be in every human? No one wants to be abandoned. Oh, tell me one person that's saying, "Oh, it's okay. My parents leave me, my spouse leave me, my best friend leave me." Like, "Oh, I'll be okay." No one looks forward to it and saying, "I'll be okay."
Yeah. And it is diagnosing BPD is pretty tricky because it also usually there's a lot of comorbid disorders going on. Somebody might have depression who has BPD, or they might have substance abuse issues. And so that can be really difficult. And if you were to go in to meet with and who a mental health professional can diagnose you with BPD, so psychiatrist, psychologist, licensed clinical.
Any therapist can do this diagnosis.
Not any therapist, but licensed clinical social worker, psychiatrist, psychologist, all of those folks are able to diagnose. And they're looking at those 9 criteria. You're also asking just a lot of open-ended questions with the client. How often have you been experiencing this? When did you start experiencing it? What are the behaviors that you are experiencing and dealing with? There are some structured like diagnostic screening tools that you can use. But again, there's no like, yep, this person has BPD. We know it. You've got
It's not like
this.
a blood test,
Yeah,
like COVID positive, negative, right?
no blood tests. No, it's open-ended question. It's self-report. It's history. Some of these screening tools, there's a couple of the common screening tools are the borderline symptom list. 23 different symptoms they're looking at. It's the BSL 23, the McLean screening instrument for borderline personality disorder. But again, there's questions of let me take a look. Like, I wanted to punish myself. I had images that I was very much afraid of, right? Yeah, I guess I did. And there's no sort of, yep, you have it. No, you don't. So it's an imperfect way of diagnosing somebody, right? And a lot of it is contextual too. Like, how long has this been going on? How much distress is this causing you? How frequently is this happening? But again, there's no blood tests. There's nothing like that to get a diagnosis. And it's very complicated because there's a lot
Yeah.
really that's also happening within that picture of getting that diagnosis.
So is it one session that they come to you and they're a client and they're coming to you and you're like, so there's some borderline traits here. Let's evaluate. Let's go through it. And is it like a one-time thing that you sit with them and you're like, okay, next session we're going to evaluate? Do you even tell them we're evaluating borderline? Or is that too scary to tell the client at the beginning before they know what borderline is? How do you go through? How does it technically happen in your office and how long does it take?
Yeah. Normally, what happens is that the folks that come to our practice, the comprehensive DBT practice that I work for, they this isn't their first rodeo. They've typically been to other therapists, and a lot of times they are referred by that therapist to, I think you might really benefit from a comprehensive DBT team. So you have that information.
So there's already a thought that they were already introduced to the idea that maybe they have that they're diagnosed with borderline, maybe, and they should go and check it out.
Yes, or that the therapist that they have been working with, for whatever reason, doesn't feel comfortable continuing to treat this client given their presentation. A lot of therapists that they don't feel comfortable working with someone who's self-harming. And oftentimes that will be somebody who will be like, maybe you would benefit from a comprehensive DBT treatment. So oftentimes that's how clients will come to our practice. They'll be referred to our practice, and there will be a pretty lengthy intake that they will have completed prior to me even sitting down with them. They'll meet with our intake person. They'll ask a lot of questions about their history with substances, their history with self-harm. So we have a picture of a snapshot, if you will, of this person, and we have an idea. Then I don't usually say we're going to be assessing you in this moment for BPD. I actually don't think I've ever said that. I ask questions. Sometimes, oftentimes, I will do one of those sort of structured assessments to just get an idea of, are you meeting criteria for this? And then because BPD is so stigmatized, it can sometimes be a little bit of a dance of, you are meeting criteria for this, but there's also a lot else going on in your clinical picture. And so you're just giving the person data at that point. And then the longer that you work with them, you can kind of start to say, like, yep, you meet criteria for BPD, you have this diagnosis. But it isn't like a perfect, like, yep, you have BPD. No, you don't have BPD. This evolving diagnosis that happens with a lot of information that and data that you're gathering about this person.
So once the therapist, let's say you diagnose somebody with BPD, you go through the analysis, you work with them on evolving this process, right? It's like, it's a slow process. It doesn't have to take months. It could take a session or two or three, whatever you think. It can even happen in a session, right? I'm understanding it can even happen in one session, right?
Yep, definitely. You can definitely do this and say, yep, you fall into this criteria. Yep, you meet diagnosis for this.
And then what is it like? Is there like this fear of how we going to tell the client that they're diagnosed because of the stigma? And do all clients even know the stigma?
It's a really good question. I would say you want to be because it's such a charged diagnosis. You want to be careful with how you relay that information to a client, especially if you don't know them very well, right? Is this going to be something that spirals somebody? What does that mean to them to have that diagnosis? And a lot of times, what I'll ask somebody is, well, what does it mean for you to have this diagnosis or to not have this diagnosis? But you want to do it mindfully, really. I think a lot of times people are very much at this point in time, very much aware of the stigma of having a diagnosis of BPD, which is part of why you want to be mindful about how you relay this information to an individual, because it is a term that has been taken and adopted, I think, especially in popular culture. And there's just so much stigma around it that it potentially could be, if you walk into somebody, yes, you have BPD. Okay, I'll see you next week. That could be really harmful to somebody. And so you want to do it mindfully, but also the flip side of that is you don't want to withhold this information from
Right.
somebody. It can be life changing. And so helpful in getting them the treatment and the care that they need. It's like DBT, it's a dance.
Yeah. The balance between knowledge and acceptance, and to turn the knowledge into power versus being a victim or stigmatized. And that's the power of a good clinician, of how to do that remarkable dance of telling somebody. Because I remember when my friend was diagnosed, she said it was like, in a way, like freedom. Oh my God, now I know. Now I know. And you watched her evolution from hell to thriving. And I remember her telling me the term living, creating a life worth living, like one of Marsha Linehan's statements, creating a life worth living. And I remember thinking, wow, what courage. Like, you're at the pits of hell and you can even think about a life worth living, and to see the evolution. But I give a lot of credit to my friend, and I say to her often that as much as DBT is amazing and as much as clinicians are incredible when they're good, like you, if the person doesn't show up, and she showed up, I have never seen a person show up like her. I've never, and I've seen many people in hell. And I'm like a magnet to anybody with any mental health struggles, because this is my passion. And so infrequently do you see people that are committed to the process of healing, committed. This episode is sponsored by BetterHelp.com. That's BetterHelp.com, the leading online platform for therapy. Many people come to me for help, and one of my questions are you willing to go to therapy? very often it is very expensive. BetterHelp is affordable. You don't have to leave your house. You can get it from the comfort of your sofa, your bed, your office. It's one click away. There are thousands of licensed clinicians on this platform. Sometimes it's so overwhelming to go to therapy. Nowadays, most therapists are on Zoom. If you want to get 10% off your first month, use the link in the show notes, betterhelp.com/hope to recharge. Use the link below and start your therapy from the comfort of your home. Millions of people from all over the world are using them. If you don't know where to start, go to betterhelp.com/hope to recharge. That's betterhelp.com/hope to recharge. Start your wellness now. And I've seen from the suicide attempts, from the despair, from the notes to herself in the future, and the dance from very happy, very sad, or literally despair. But to see the transformation, people in a lifetime don't do the transformation that she did in 3-4 years. Transformation, a different person, thriving, relationships, happy, giving, doing, and
Yeah.
empathetic and sympathetic, and a member of so many communities. Who would have thought that DBT can do this,
Yeah.
right?
And to your point, DBT is this framework, but it's her, it's the
Her.
client, it's her,
Exactly.
it's the client, it's a
It's the
person,
showing up.
it's the willingness to feel
Yeah.
really uncomfortable and to keep going and to feel
Right.
like you've down a million times and to pick yourself back up and keep going. Like DBT is great. Trained clinicians are so important, but at the end of the day, like it is the individual
Yeah.
that is
Yeah.
the hero
Yeah.
in these stories.
No one can heal somebody if they don't show up. No medicine, no therapy. If the person's not doing the homework, not doing the exercises, not analyzing, and she's like the most incredible student and I think
Yeah.
warrior of life. Really, she's a mentor for me of not giving up, and I didn't see many people like her. And
Just to
reflecting and self-reflection and growth and awareness. And the more I hear about, and I'm going to bring it back to DBT, the more I hear about DBT, the more I think, why is it only for the borderline community? This should be a tool that's taught in kindergarten because there's so many things that I learned through her. Check the facts, and I'm using it for myself. So often I'll say to her, oh, I just did it. And she's like, that's a DBT skill. I'm like, really? I didn't even know that. Like naturally, I do my self-healing or boundaries or repair and she's like, "Oh, that's a DBT skill." And she'll name it and she'll tell me all about it. And I realized like if I had these tools many years ago before my crisis, I think my life would be different. But in a way, like when I fell apart 13 years ago with my deep depression and anxiety, I think it was an awakening to me. And maybe if I was given the tools as a little child, I don't know, but I feel like the DBT should not be only for the borderline community. It should be for any individual. It could be for relationships, for growth, for self-reflection, right?
absolutely. I could not agree more. And the reality is that since Marshall Linehan created her treatment, put out this text in 1990, like cognitive behavioral treatment for borderline personality disorder, DBT has really evolved. That it is not just a treatment right now for folks with BPD. This is an interesting piece about diagnosing it that I think is just interesting is that you as a clinician cannot technically diagnose somebody under the age of 18 with BPD.
Oh, I wanted you to touch upon that. So let's talk about that.
It's the idea that they're kids, they're developing, they're evolving. Do we want to diagnose somebody with personality disorder under 18? No, we don't. But I will say that working in the field for a while, you will see somebody who's 16, 17, right on that cusp that you're like, this person meets criteria for BPD. They meet criteria for it, and it could be very helpful to give them that guidance and direction. But technically, you're not supposed to do it, which creates that makes it again stigmatizing. Like I can't tell this person that they may be meeting criteria for this thing. But all that to be said is that there really has over time, DBT now has been adapted for substance abuse. It's been adapted for eating disorders. It's been adapted for adolescents and kids. And one thing that I hear all the time from, is I run a couple of skills groups, which is just kind of part of the comprehensive group, from parents, because in a DBT adolescent skills group, you have parents and their children in the group, is why don't they teach this in school? Like, this is
Mm,
why don't they teach these skills in school to kids? Like, this is just these are just skills for being a human and living in a world that has pain. These are skills for anybody, BPD or otherwise. And I couldn't agree more with that.
yeah. Okay. I'm glad we touched upon that. And I really wanted to highlight that there is no diagnosis before 18. And I'm curious to know, do you know why there's no diagnosis before 18? Is it because the brain is not formed yet?
It's that idea of, do we want to diagnose somebody with a personality disorder before they have fully developed? But it's arbitrary, right? It's an arbitrary 18 as an adult, it's an arbitrary number.
Right,
But
right.
there certainly have been kids, 17, 18-year-olds, who I will start to talk, that I've worked with for a long period of time, that I will start to talk to about this diagnosis and say, you are meeting criteria. Technically, we can't give you this diagnosis. And what do you think? What do you think about this when you look at it? And it can be really helpful for them too, to say, oh yeah, I knew I had depression, but there was something else going on here. And this just makes so much sense to be able to put these pieces into place and say, yeah, I feel my emotions more strongly. I feel them in this way. And this makes a lot of sense to me, that this is also something that I'm experiencing and that's going on. And that's part of my picture
Mhm.
and what I'm doing.
And to just keep an eye on it. And
Yep.
they could start DBT at any age and start
Yep.
applying things. I think what I wanted to touch upon also is that there is remission from borderline, right? Let's talk about that a
There
little bit.
there most certainly is remission from borderline. I think that's one of the most important things to take away from this, is that you get this diagnosis, but you can absolutely not meet criteria for that diagnosis over a certain period of time, right? Working DBT skills, there are certainly people who've come in who I've worked with who meet criteria for BPD. And after years of working the DBT skills, really applying themselves, no longer meet that criteria. And I think that's really hopeful and inspiring, to say this thing, this personality disorder, can essentially go into remission. I don't have to suffer from this thing with the appropriate treatment and the appropriate care.
And it's not my identity. I'm not borderline personality disorder,
Yep.
BPD. I am who I am, and my diagnosis is not me.
My diagnosis, there may be a part of what's going on with me, but I am something else. And I do have, and I think that this is the beauty of DBT, is it has this thing called the biosocial theory that I referred to before, that talks about what leads to behavioral dysregulation. And it is non-pathologizing, right? It's not like you're in psychosis or you're neurotic.
Right.
It says behavioral issues, behavioral dysregulation
Mm,
comes from a transaction
mhm,
between a biology that's a bit more sensitive than
mm,
somebody who doesn't have this wiring. You feel your emotions more intensely than somebody who might not have this wiring. Your emotions stay elevated longer
mm,
than somebody else who might not have this wiring. And yes, you may be a bit more sensitive to things.
mm,
That alone doesn't lead to behavioral dysregulation. What leads to behavioral dysregulation is that biology transacting with an environment that is, what in DBT, the language they use is invalidating, which has
mm,
somehow communicated to that person that they are wrong, they are weird, that they're not fitting in. And a sensitive biology like that, transacting with an environment that's saying, like, what's wrong with you? Or it can be as subtle as being born into a family of extroverts and you're an introvert, and the
right.
holidays come and everybody's excited for the
Mm,
holiday party. I just don't want to see everybody. I want to stay in my
right.
room.
Right.
Everybody's, what's wrong with you? Why are you so antisocial?
Right. Right.
And that can lead to behavioral dysregulation. And so it's this non-pathologizing way of looking at these behaviors, which is so really revolutionary, right? Because it
Mm,
says we have to treat both of these things,
mhm,
and you may not meet criteria for BPD anymore, but you do have this wiring that's a bit
mhm,
more sensitive. And you just got to be mindful of that as you move
mm,
through the world. And that, particularly invalidation, can be a really it can be a hot spot for you. It can be difficult for you. And yeah, I think that DBT does such a great job of outlining
Mm,
that.
wow. So that's interesting. So I'm wondering if the people that if they were diagnosed, if they were given DBT skills when they were not feeling balanced or they were feeling like, what's wrong with me? If they were given the tools earlier, would they maybe prevent this escalation to a diagnosis, maybe even? Because
Sure. Yeah.
basically the DBT is the one is what's helping them go into remission because they have the tools. So as you said, there are always going to be sensitivities, and the wiring is like that, but it's just awareness that the outcome is different because I have the skills of dealing
Yeah.
with it. So it's the tools, basically.
It's the tools, it's the skills, it's the information, which again is another reason that if there's a kiddo who's 14, 15, who might be exhibiting sort of BPD
Hmm.
symptoms, but they're already in treatment, we don't need to give them that diagnosis because maybe they will have skills and tools so that they can deal with the invalidation that they're experiencing or these intense emotions and go into remission before they even get to 18. And so
Right,
we don't
right.
give them this label that so can be so helpful in some
Mhm.
respects, but can also be heavy for some people, can become somebody's.
So what I'm thinking and understanding is that if there wasn't such stigma and there was more acceptance, no one would be afraid of the diagnosis. The diagnosis is a fearful thing just because of the stigma, not because of anything else. Because they're going through the same motions and they're going through the same experiences. It's just this fear, will I be accepted? Will I be denied? Will I be labeled?
How is a therapist going to look at me if if I go in and say I have BPD?
They look at me differently.
They look at me differently. When Marshall and there's I can't remember if I watched this in a video. If you go to a hospital, do not tell the staff that you have a BPD diagnosis because they will treat you differently.
How
And
was
that's
that?
the creator of DBT, which is just, I think, speaks to, again, the sort of nuances of this diagnosis and how harmful and helpful it can be.
Wow, that's
But
just like awful.
yeah, and I loved
Like,
what you said about the diagnosis itself isn't that scary a thing. It's the stigma that's been built up around it and the way that we talk about it that has created it to be this very scary thing.
so I guess we know what the fear is the stigma and the labeling. And will I go into remission? Will I survive? Is it a deathly sentence? Do a lot of people that are diagnosed with borderline, do they harm themselves forever? Are they more prone to suicide? Will I kill myself? So what's the positive thing? We know the fearful, the stigma, the shame, the buzz in the world, the lack of acceptance. What's the positive part as a therapist and as somebody that saw a lot of clients going through this experience? What would you say is the positive thing of telling somebody your their diagnosis with borderline?
Yeah. I think that we've touched a bit on it, but I think that it is and can be incredibly validating to receive this diagnosis. To say, oh, yeah, I do feel my
Mm,
emotions. It can be really validating to say, I knew something else was going on. I knew I didn't just have depression or anxiety or these diagnoses that I received. Okay, yeah, it makes a lot of sense that I'm feeling fearful of being abandoned. So it can be really validating,
mm,
which is so important. I think in the treatment in working with someone who has this diagnosis, it also can point somebody in the correct direction of treatment that's actually
mm,
too harmful. Because as you can imagine, as we've been talking about this, putting someone who has this sort of picture, this clinical picture with a treatment that is pathologizing, that is, ooh, why did you do that? Or what
mm,
is this sort of assuming rather than assessing can be incredibly detrimental to somebody's
mm.
care. So a great part of having this diagnosis is it can give you hope and direction
Yeah.
to appropriate care and services. Yeah.
Tremendous relief from the pain.
Yes.
And
Yep.
I think the validation and the relief and knowing, I think just having that hope and saying, okay, this, it's like somebody diagnosed with, God forbid, cancer. Okay, do you want to just say, okay, you might die, or do you want to hear about the treatment that you can survive and you can heal and you can live a life, right?
If you're not getting the appropriate care, it runs the risk of continuing to further invalidate. And
Mm,
that's what we know leads to behavioral dysregulation, emotional dysregulation, is that invalidation from the environment. And what is more invalidating than a professional saying,
mm.
"Oh, you're just attention seeking." What it that is like,
Oh my
and so
God.
that diagnosis can help point you towards folks who can have a language, have a treatment that is actually helpful as opposed to harmful or further invalidating.
And I think also set boundaries for yourself because, okay, this will not be healthy for me. This is okay for me. This is what I need. And and create a lifestyle that
Yeah,
supports your sensitivities versus having to constantly repair these sensitivities that you feel broken from.
yeah,
So,
absolutely.
building a lifestyle is important. So, I want to touch upon Marsha Linehan. We're going to go into understanding DBT a little bit and how she came about creating the DBT.
Yeah, she created the treatment. She
Mm.
created the whole treatment, this entire modality, DBT. She created it, the
And she
whole
created it
modality.
out of her own experience of borderline. Let's give the listeners a little bit of a background, like a 2-minute background on Marsha and what she created.
Marcia, she grew up in Oklahoma. By all accounts, she said normal childhood, but she said she never really fit in. Pretty early on, she started to experience a lot of depression, suicidality, and she was hospitalized inpatient. And that's where she actually says that hospitalization further led to her behavioral dysregulation. And over time, she's just amazing, and she was able to pull herself out of hell. And she made a
Alone.
promise to through, yeah, she had treatment, but she really says that treatment was not particularly helpful, which is something that this is a little bit of an offside, is that so often people will see someone who has BPD and say, you got to go to the hospital. And what we know is that is not usually helpful. But a lot of times that is not the thing that is helpful. And so she experienced that. She went through it firsthand of, oh my goodness, we don't know what to do with you. We got to put you into hospital. And as she pulled herself out of hell, she made a promise to herself, I'm going to go into hell and I'm going to pull as many people out as I can. Brilliant woman. Went to the University of Washington, and this was her mission, to create a behavioral therapy to treat. And at the time when she created it, she wasn't even thinking of BPD. That wasn't even really on her
Oh,
radar.
she wasn't diagnosed with borderline? Or was she?
It's really interesting. She certainly met criteria. I've never actually heard her say, I had BPD, but
Hmm.
she definitely had suicidality. She definitely had self harm behavior. She met 5 out of those 9 criteria. But when she created DBT, she actually was trying to create a treatment for self harming, suicidal individuals. That
Mm,
was her focus. But to get the grants that she needed, they needed a diagnosis, and the diagnosis was BPD.
mm,
And because it fit most closely with the symptoms that she was treating.
mm,
And she was at the University of Washington, and through her own lived experiences and her just devotion to behavioral therapy, she created DBT. But what was really interesting about what she did with DBT was she was a behavioral therapist, which behavioral therapist is all about change. What
mm,
she noticed with that was when she just went in with change and was like, this is something you got to change. You got to do opposite action here. Was that a lot of clients would not stick around, or not, that wouldn't be enough. And so she paired it with acceptance and validation, right? This is where you're at right now. This is what's going on. And that's really, I think, the beauty of DBT, is this sort of dialectical dance and balance between change. Your life is not where you want it to be. And so you're
mhm,
going to have to change some things, and acceptance. This is miserable right now, and you are trying the best that you can. And those
mhm,
two things can be true at the same time. And you're constantly, as a client and as a clinician, titrating between these two ends of the dialectical spectrum of, you're doing the best that you can given this current moment and where you're at. And if you want the life that you want, you might need to change some things. And that was the underpinnings of DBT, and how she created it. She did some studying with a Buddhist monastery, which is how she got the mindfulness skills and really broke them down into tangible things that people can do. And then a lot of just perfecting it, seeing what created sort of the best package of DBT. Yeah, it's a
It's
short.
yeah. So is it like a whole book about tools and skills? Like how when somebody's I just raised my it looked like I raised my hand. Hold on. When you start with DBT, like there's so many skills. How does one even start learning? It sounds like a whole profession in itself, like DBT skills.
Yeah, so can give like a basic outline of treatment, like what you would expect in treatment and how you would learn those skills, because it is a comprehensive DBT has a couple of different modes of treatment. So the first thing that would happen if you go in is you would get pre-treatment. And pre-treatment lasts about 4 weeks. And in that period of time, like the clinician's assessing, you're also orienting the person to what DBT is.
Mm.
And you have like clear definitions of the expectations of treatment going in. So there's no surprises because
So it's very different than traditional therapy at all. There's very
it is.
little empathy and talk therapy. It's more a plan.
It's more a plan, and I actually think that this part is really a cool part of DBT is that there's no Wizard of Oz behind the curtain. Have you ever gone into a therapist where they're like, but you're
Mm,
like, what are you thinking? What's the meaning?
mm,
This is what we're doing. This is what's happening. This is what we're doing. It's very clear
mhm.
expectations. And in a way that is to put both the clinician and the client on the same level. I have a certain set of skills that I can give you, but we're just two humans trying to work through this together. But there's no mystery of what's going to happen. And it is a big commitment to sign up for a DBT comprehensive program. A lot of comprehensive programs want you to sign up for 1 year of DBT. And in that year of DBT, you have your individual therapist and your therapy, which meets once a week, usually for 45 minutes to an hour. But then you also have a skills group that you're meeting once a week. And that's where you learn the skills of DBT because those are the tools that you're going to be using out and about. And in that skills group, which takes about 6 months to go through all of the skills. And a lot of folks will go through the skills group twice, which takes you to about a year.
But you have to.
You have to.
So that means you
Yes.
have to really be all in, all committed. It's like an AA meeting in a way. I'm coming, I'm showing, I'm revealing myself that I'm part of this agenda of healing and I have to show up for myself. And it might be shameful because it's the beginning with acceptance, the radical acceptance that Marsha talks about. So it's a big commitment. If someone's doing it, that means that they're all in.
They are all in. Yeah. And that's why pre-treatment usually lasts about 4 weeks because you really want somebody to know what they're getting if they're signing
Yeah.
up for it, because it's a big commitment. You're meeting with a therapist once a week and you're talking about your own personal situations that have come up and
Mm.
how you personally have applied the skills. And then you're meeting once a week for 2 hours, between an hour and 30 minutes to 2 hours, where you're learning the skills. And you're doing that for 6 months at a bare minimum, usually a year, when you sign up for a comprehensive DBT
Wow.
program. Yeah.
Wow. And people coming into your office know this. They know if they were referred to you that if they're starting DBT, your it's your private practice or you're part of
I'm part of a group practice.
so they know if they're coming to you, they know that coming to you is not just coming for therapy. They're going to have to also join a group therapy. They know this in advance.
Yes. And I will say that's something that the clinician and the client, you're figuring out in those first couple of weeks. You're figuring
Mm.
out in that assessment period when you're talking about BPD, when you're doing some of
Mhm.
those assessments,
Mhm.
and deciding like what is the best course of treatment for this person. Because a comprehensive DBT program, it's a big lift.
Right.
And if you do it, okay, there's other ways there's other ways to do it. But if you need comprehensive DBT, you better know what you're signing up for. And so before somebody commits to it, there's a large runway for you as a clinician to orient the person to what this is you're signing up for, what this is that you're getting, which you're getting individual, skills group, and then the other component that you get, there's two other modes of treatment in comprehensive DBT, is you get phone coaching.
I wanted to touch upon that because it's very different with traditional therapy is the phone coaching. And a lot of times people that are first diagnosed with borderline, they could be alone for their self-soothing. They need a lot of support.
They're
They need a
hurting.
lot of
They're really
handhold.
hurting. Yeah, they're really hurting and they
Yeah.
really want relief and there's
Yeah.
to do to get that relief.
They need
And
support
sometimes they need
and
support.
guidance and guidance.
Mhm.
Yeah. So I think one of the is this a did Marsha Linehan came up with this idea of the phone coaching? So
Yeah,
tell me
and
about that because for me it was like my mind, like, what? You can text a therapist in between sessions. I always said, what do you think? You go to 45 minutes, 50 minutes, an hour. What happens with the hundreds of hours in between those? What happens? You opened up a wound. You literally opened up a wound to look at it. And sometimes you're just before you're about to make the wound feel better and you're like, okay, we'll see you next week. What happens the rest of the week? How do people survive? I think something has to change within the therapy community in general to be more like DBT. So let's talk about that.
phone coaching is a really unique part of DBT. And the function of phone coaching is to help to generalize the skills that an individual is learning in skills group. And so it is not, and this is really, there's a lot of conversations between client and therapist about what phone coaching is for and what it's not for. What it's for is you are in a crisis. You are on the verge of engaging in a behavior that you've been trying to stop. Let's just take self-harm. You don't want to do it, but you're having really strong urges. Phone coaching is for exactly that moment. It's before you engage in the behavior. Call the therapist, say, I am struggling. I have tried this skill. I'm still feeling really intense urges.
So they have
And
to name what they did. You can't just say, I'm struggling. You have to say, okay, did you show up for yourself? Did you use the skills that we taught you to use? It's not for me to give you empathy and not for me to save you. It's for me to guide you and make sure you use the skills correctly. And if not, what's the next plan?
if somebody calls, and this is a really tough
The
part about
hardest part. Oh my God. This is the part that I feel like you are an angel because it's the hardest part. It's the hardest part. So go tell me about it.
the hardest part is to keep your limits. At least the hardest part for me as a therapist
Yeah.
is to keep your limits clear and strong about what phone coaching is. It's because a lot of times too, people when they reach out for phone coaching, sometimes it can just be they're lonely, right?
Yeah.
Or they're just I'm hurt. And so to keep your limits and say, are you looking for skill support? Are you looking for phone coaching right now? And if not, okay, I'll see you in our session. The other thing too, and this is, I think, one of the most difficult parts of phone coaching is if a client calls and says, I'm having urges, say, what have you done? And then you as a therapist say, are you willing to take a suggestion to use another skill?
I love that. It's so powerful because so many times in healing in general, people just want to be heard. And what part of you wants empathy? My husband often says to me, do you want me to listen or do you want a suggestion? Just tell me what you need now.
Yeah. And it's so tough because on a phone coaching call, you don't want it to become a therapy session. And so if somebody isn't willing to take a skill suggestion, you as a therapist, okay, then that's what you need to work on. I can't do anything for you
Oh
if you
my
are not
God.
willing to do it. I'll talk to you later, or I'll talk to you when you are willing. Call me back when you are willing to take a suggestion. And then you got to hold that line,
Wow.
which is the really tough part.
Which is the
That
hardest part because with a borderline client, they're dealing with abandonment, rejection, extreme emotions, and they can feel like a rejection and it can take them to the next step of maybe even attempting suicide or maybe doing the urges but the only way to heal from that is step into the skills because me not rejecting you is not going to help. It's just a
totally.
whole other episode, right? We have to talk about a whole other episode about this, but I can't imagine as a therapist how hard it could be. Like, how hard is that?
I would say that it's probably, if not the most difficult part of the treatment for me, the most difficult piece is to just say, are you willing? No, you're not. Okay, I'll talk to you when you're willing. Right. It
And
is
then you
because
don't
it's
know what happens after. You as a
There's a piece within phone coaching that says because you really want the individual to reach out for phone coaching before they engage in the problem
right.
behavior, for lack of a term. And within adult DBT, if somebody engages in self-harm and then they call you and they say, hey, I just self-harmed and I'm calling you, for you as a clinician say, okay, there's what's called the 24-hour rule. If you did self-harm, I'm not going to be able to phone coach with you for 24 hours.
Oh, so there's like a consequence.
There's a bit of a consequence.
Did you
And the
call it a
idea,
consequence? Is what's the terminology? A penalty? What is that? Or
yeah, that a
what is
contingency, I
a
suppose that you
contingency?
could say,
Okay,
a
fine.
contingency.
Okay.
The idea
Because
here,
you want to know, you want to give them to that step before. Think because you know that there's going to be an outcome that you will hurt from. Like this will harm you more.
yep, and that's a big, this is a whole lot, is when you do a chain analysis, which is when you look at a behavior that you've engaged in that maybe you didn't want to, a big focus is what were the consequences. And consequences are what were positive outcomes, but what were also negative outcomes. And that
Mm.
24-hour rule with phone coaching is I wanted to talk to my therapist after I self-harmed, and they wouldn't take a phone coaching call for me for the next 24 hours. And that really sucked. And I didn't want that outcome. But that's a consequence. That is a consequence of doing that. And it's also, again, to say really clear on what is the function of phone coaching. It's not so much support, it's generalization of skills so that the person is using those skills in their own life of their own accord. Yes, maybe I helped guide you to it and gave you some encouragement to do that. But at the end of the day, the goal is for really you to become your own DBT therapist. And phone coaching really tries to stay focused on skills application and generalization as opposed to anything beyond that scope.
Do you feel that the first 6 months, the phone coaching is used much more than after the first 6 months?
A
Yeah.
hundred, like the first
So
6 months.
so if somebody feels like they're overusing phone coaching, just be hopeful. It's what happens and it's getting used to it. It's getting used to the balance, the dance, the awareness. Do I need it now? Do I not need it now? Should I lean on it now? Should I not lean on it now? Just that internal guide takes time to know well.
Absolutely. Yep.
Mm.
Yep. And that takes time, and behavioral change takes time. And so you can expect that early in treatment, someone is going to reach out for phone coaching a lot more than if they've been in treatment for a while, and have those skills and tools.
As a therapist, technically, you're in session and you're getting text calls. Like, how does that work? Like, you're sleeping. Where's your boundaries of life? Like, when does your day start? What if it's 2 o'clock in the morning and somebody's saying, oh, I'm attempting suicide and they want a phone coach, but they can't because the therapist needs to sleep? How does the therapist balance that? And what happens if a client needs a phone coaching at the time? Is there a 911 for phone coaching, like a group? How does it work?
That is, they talk a lot about clinicians' own personal limits, and clinicians' own personal limits are different. I think the most important thing is clarity to the client of what they can expect, so there's no surprises. But I do think that this kind of gets to something that Marcia has said about DBT, is that DBT is not a suicide prevention program. It is a life enhancement program. Just
Say that again.
um,
Oh, I love that. That's gonna be our intro. That's our
yeah,
intro. Let's say that again. I love that. I think people need to know that.
DBT is not a suicide prevention program. It is a life enhancement program. And that is, in my mind, as a therapist, I think about that a lot with phone coaching, right? I will give you my time, but yeah, I sometimes have back-to-back sessions where I'm in sessions for 2 hours, but I can't get to somebody because I'm giving this other person that I'm in session with my time. And so there's a lot of, if you are in crisis and you can't keep yourself safe, use your skills, try phone coaching. And if you still can't keep yourself safe, you got to go to the emergency room.
I can
I
keep
can't
you
do it.
alive, and it's not
Yeah.
my job to keep you
And that's
alive.
not my job. Yeah. I keep that in mind a lot when I think about phone coaching, its function, my limitations as a human, and like what I can give and can't give, and what I'm trying to do here as an outpatient DBT therapist.
I remember a few times my friend would call me and she's like, I can't use phone coaching for this week or whatever. I abused it. And she was heartbroken. I would say, you don't understand your therapist. She has heartbreak because she wants to save your life now. And she knows that if she doesn't stick to the boundaries and the guidelines, she's not helping you heal. She's really it is the hardest thing. And I remember saying it so many times, you understand this is the epitome of love and kindness, of saying, I'm doing this for her, even though it's brutal. And it's so much easier to just say, okay, I'll talk to her for 5 minutes or 10 minutes and whatever, or give her some hope versus saying, I'm
Yep.
sorry, I can't talk to you. We'll see you next session.
Give you some encouragement. That's so easy to say, come on, you can do it. Like
Exactly.
that's not the function of it. And I will say the other mode of treatment in comprehensive DBT, and this is really important, is you are working on it as a therapist. You're working on a team with other therapists who have DBT cases, and talking about phone coaching, talking about the emotionality that comes up for a therapist when they see somebody reaching out, but it's not effective phone coaching, and having urges to save or rescue or jump in there and just have that call is a huge part of that comes up in that consultation group of how do I really wanted to take the call because I could tell they were hurting, but I know I shouldn't. And so that's a huge part of what that consultation group is for, is to help support other clinicians in being able to stick to the modality, stick to the treatment, because that's really hard.
So, because you were human. We're human.
Gone into this field to help, to want
Right.
to help, and then to say, okay, no, in this moment, help actually looks like sticking to that 24-hour guideline.
Yeah. Wow. So let's say you go on vacation for 2 weeks. Do they have a different therapist that takes on phone coaching for those breaks?
Yeah, depending on where the person is in treatment, which again, somebody who maybe has been in treatment for a while, they might not, they say, I'm good. You go on vacation, I'll be good. Other times, especially in that first 6 months of DBT, that's why you are on a team. That's why comprehensive DBT always has a team component to it. And typically you'll have somebody on your team say, I can cover for you. I can cover phone coaching for you during that time. And that's what that piece looks like.
Wow. Did you ever have a client that reached out for coaching and died by suicide by the next session?
No, but I certainly have had clients who've reached out and had phone coaching and then self-harmed or something like that. But I've never had a client reach out and by suicide.
So I think that says a lot about the community, that they really want to live and they really want to find relief. And they'll do hard stuff, which most people don't have these challenges, but they're going to do hard stuff in order to gain relief. And it's incredible, this DBT world that was invented. Marsha like really made such an incredible program. Like, it's mind blowing. Does it evolve with time? Does DBT evolve with time? Is there like updates, changes?
Yeah, behavioral tech is the agency, the company, I'd say, that sort of leads the charge on DBT. And they have yearly conferences. There have been some adaptations to DBT, like I was saying, to like there's now DBT for adolescents, there's DBT for children, there's DBT for substance abuse, there's DBT for eating disorders. The foundation is still the same DBT, but there's slight tweaks, adaptations, things like that. And I think that they're always looking to see their blind spots and where they can improve and give really the gold standard of treatment. And that evolves, which is part and parcel of taking a dialectical mindset, is like change is the only constant. And so we have these things, we have these principles, but we are also fallible and things change. And with that, sometimes we have to change with time. Yeah.
Wow, Meg, thank you for giving me a background, a deep dive into borderline. We touched upon DBT, touched a little
Yeah.
bit. I want to do a whole segment to take the most popular DBT skills that are used and how you see the transformation and how it helps people. And I also, maybe, I don't know if it's too much for one episode, but I want to speak about the family member or loved ones with someone that's diagnosed. How can we support them? What could we know? What do we need to know more about DBT or borderline? Is there things that we could do as loved ones? What we shouldn't do as loved ones? For example, same boundaries that you keep, do loved ones also keep in order to give permission to the client, the person that's struggling, to heal and not keep them in the same position. I also want to speak about how is borderline, like the brain function of like how is borderline brought up? Is it by trauma? Is it in our DNA? Is it something we're born with? Is it like, what is that? What does borderline come from? I think it comes from trauma, but I'm not sure. I want to deep dive into that. Neuroplasticity. Is DBT neuroplasticity or not?
It definitely there definitely are relies on those principles that the brain has that ability to
Right.
change, adapt.
And another question that comes up is is every person that's diagnosed with borderline highly sensitive person an HSP? We'll touch
You know,
upon it. We don't have to answer. But these are questions. Like if somebody's highly sensitive, does it mean that they should check out to see if they meet the criteria as a borderline, or there's similar traits, but it doesn't mean that you are. And what happens if somebody has 3 traits and they're very intense? What does that
yeah,
mean? And
yeah,
maybe we
yeah,
need to
a lot of questions.
yeah, a lot of questions. I feel like a lot of this the stigma, and I want to really focus next time on like how can we reduce the stigma to
Yeah,
enhance the recovery? Reduce
yeah,
the stigma in order to empower recovery.
definitely. And I do think that one of the things that I think is so hopeful to me is that people who have this wiring or have that genetic predisposition for BPD, if given the skills, are some of the most compassionate, creative,
Oh,
advocate
thank you for saying that.
people. They're great public speakers. They're fun. They're the cool. This is a judgment, and they're the coolest people to be
It's
around.
true. It's true.
Truly. And so I think that is just so important is that given the skills and the tools to rein this and control this, and them being in control rather than their emotions controlling them, they're the coolest, most creative, interesting people you could
And
ever find.
kind. I want to say kind, empathetic, intuitive, right?
Yeah. They've been there.
Super
People often
creative.
they're advocates for minority, like they are like the best people.
Yeah,
Judgment.
yeah.
And
No, but
truly.
I do think that I'm so happy that we're ending with this because with all the hardships and the difficulty that comes with borderline, there's such a beautiful facet on the other side that comes in the full picture, the full spectrum of somebody that has these sensitivities. They are really some of the most creative, kind, genuine, empathetic, non-judgmental humans out there.
Absolutely.
And I'm gonna
Like
say that firsthand from knowing a bunch, and I'm like, "Oh," and part of me is like, "Oh, now I understand why you're like this because you're diagnosed with borderline. Of course you're cool. Of course you're kind. Of course you're sensitive. Of course you're intuitive. Of course you have these highs and lows and whatever, and permission to not be with people." Like, "Oh,
yeah,
yeah, cool."
yeah, 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 passionate, like just the best. And I think that's such an important flip side of it is sure, maybe there's a biological wiring there that can create some of these challenges. But on the flip side is given the correct treatment, the correct tools, man, they're just amazing humans. Some of the most amazing humans I've met have a BPD diagnosis.
Yeah, yeah.
That's really important to highlight.
So I could probably wrap up and I often say that my clients are my inspiration, and sometimes I'm like in awe, and I think you would say the same.
Absolutely. Their grit, their resiliency, their empathy, their compassion, their ability to have gone through their life experiences and to still have the depth and compassion and empathy that they have is just it, it truly is inspiring.
And to see them showing up and showing up and showing up. Yeah.
Yeah.
Meg, thank you. Thank you so much. We're going to continue this series because I think this is so important for the world to know back to basics. Okay, let's break it down. Let's take this big monster of misconceptions and just make it human and make it very simple and bite sizes that we can support those that are going through it and understand them and give empathy and maybe hopefully break this stigma that people will be okay going into the hospital or going into a room or telling their friend, oh, by the way, I was diagnosed with borderline. I'm struggling. This is how you can help me.
It is a mission that I am behind 100%. And it's been really a pleasure and a joy to speak with you today. So thank you.
Thank you. Bye till next time. Thank you for listening till the end. We highly appreciate all of our listeners. In Mental Health Together is better. You being here means a tremendous amount to us. If you enjoyed this episode and you would like some extra boost of information and inspiration that is not on the podcast, you can go to our website, hopetorecharge.com. There's some premium content that for the cost of a cup of coffee, you can download some amazing information that will help you, a tool that will guide you through life. So don't skip a beat. Don't hesitate. Go to hopetorecharge.com and see what other offerings we have there for your mental health well-being. Thank you for joining us. And remember, if you enjoyed this and you want to say thank you, the best way of gratitude will be by you leaving a review or a comment or sharing this with a loved one. There is no greater form of gratitude for us. Thank you. Bye till next time.
Looking to reduce your anxiety and stress, relax your muscles, or get a better night's sleep? Check out Maxifys.com, 100% legal hemp, where you can find doctor-formulated, lab-certified, high-quality CBD oils, tinctures, and other items, cultivated, grown, harvested, and packaged in the United States, and available in different sizes and strength formulas. Check out Maxifys.com, that's MAXIFYZ.com, and use coupon code HOPE to get 10% off your order plus free shipping. That's Maxifys.com.